Hello, everyone. Thank you very much. Welcome to the final review. Let's get started. So let's go next. So which of the following factors contributes to the justification for fractionation of radiation treatments? And I'll just give you a couple of minutes there to look at the selections, and then we can move on to the next one. Okay, Andrew, we can hit next, and they can see which answers. Okay, so if you got a chance to at least look at that question and review those choices: redistribution, reoxidation, repair. Just think about your radiobiology, your 4 Rs. And you will know that fractionation does not reduce tumor cells back to the germ cell state. And of course, revenue has nothing to do with, there's no clinical reason for this. In what phases of the cell cycle are most cells sensitive to radiation? Okay, we can go to the next slide. Okay, you have your G2 and your M phase, which are the most radiosensitive. Okay, which interaction in the cell contributes the most to destruction of the tumor, and choose the best option here. Okay, I guess we go next. And the answer is radiolysis of water forming hydroxyl radicals. So again, if you think about your interactions, you know that water is the highest component in the cells. So when they do interact, free radicals are formed. And that is the most effective way to destroy DNA. Okay, in a therapeutic linear accelerator, dash are accelerated towards the target, produce a beam of photons. Okay, and next, electrons and tungsten. So that should be pretty obvious with how a linear accelerator works. Okay, next one. Okay, advantages of linear accelerators over cobalt-60 machines, including which of the following? Okay, LINAC beams can have a greater Dmax. The field of the LINAC have smaller penumbra. LINACs can use electron beams to treat superficial injuries, and LINACs require less vault armor. I'll give you a couple of seconds there to think about your answer. And again, it's you choosing the best option. Okay, and we can move to the answer. And LINACs do require less vault armor. LINACs produce higher energy, so you would need more armor around it. Okay, what factors influence the construction of a PTV from a CTV? Again, from a PTV, of a PTV from a CTV. Okay, uncertainty in the patient setup, organ movement, proximity to a critical structure, extent of microscopic disease. I'll give you a couple of seconds to think about those options. Okay, yep, 1, 2, and 3. Okay, so again, yep. Next, in simulation in 2D, choose the best option. Is it better to draw treatment fields with a narrow tumor margin to preserve more normal tissues? Treatment fields are positioned based on the location of the tumor in relation to normal tissue. And a CT scan should be used to plan treatment. I'll give you a couple of seconds there to look at that. Okay, next for the answer. Okay, and the answer would be B in this case. The treatment fields are positioned based on the tumor location of the tumor in relation to bony anatomy. If you're just doing a 2D kind of treatment, for example, an APP, you can use bony anatomy to locate for location of your tumor. So that would be more than enough. Okay, RTT has less work during IMRT treatments than 3D treatments because no need to go back to the vault between fields. The plan runs automatically, so the RTT can simply relax during treatment. No verification is needed as the plan has been verified twice by physics. Images are only required during the first treatment. I'll give you a couple of seconds. Okay, and we can go to the answer. And that is correct. No need to go back to the vault between fields. And again, even just thinking about that question, it's not really less work, so to speak. We always have to be vigilant. We always have to make sure that we are paying attention to what we are doing, making sure that we're looking at the patient throughout the treatment. So yes, so no need to go back to the vault between the fields. So no time to relax. Next. Okay, with megavoltage beam energies, the photoelectric effect is predominant. I'll give you a second to think about this because even I had to think about this. And so just remember your interactions, the answer, and faults, correct. megavoltage beams, it's the Compton effect that's predominant. Okay, next. Okay, identify which of the following images uses MV energy. And this should be pretty obvious. And we can go to the answer. Okay, and the answer is C, and mainly because we know that MVs are high energies and they do cause more scatter radiation. So because of more scatter radiation, the film has a lot of radiation density. And so there'll be a lot of fogging. And so the image is not, so it does reduce the image quality. Shown represents, I'll give you a second to think about this. It might not be so obvious to some. Okay, next. And it's the picket fence test, which is used for your MLC QA, basically to check the MLC leaf positioning. Okay, next. True or false? IMRT planning is done using dose target. Therefore, precision during patient positioning is very important. And I'll give you a second. And yep, we can go ahead and show them the answer. Go ahead. All right, and it is true. With IMRT planning, as you know, it's inverse planning. So precision is very important. So your patient positioning is going to be very important for you to when you're delivering IMRT, because if they're not, then you could potentially be missing the tumor. Which imaging modality is best when targeting soft tissue such as lung tumor? Again, I'll give you a second. And again, this one should be pretty obvious, but okay. Ready? Next for the next. Yep, CBCT. So CBCTs are very good for soft tissue. They do give you a 3D visualization. So CBCT would be your best option for this. Next. Due to the possibly daily variation in the patient's position, which of the following is an appropriate action? Make sure the patient is comfortable in the mobilization device during simulation. Use the IMRT technique because it's more accurate. Instruct the patient to breathe deeply during treatment. Use tighter margins in treatment planning. I'll just give you a second there to think about the best option. Okay, and we can show the answer. Correct. So making sure the patient is comfortable in the mobilization device during simulation. So again, if actually right now I am doing most of the simulations where I work. And so simulation is the first step, and it's very, very important. You want to make sure that your patient is comfortable and that they are immobilized in a way that can be reproduced every day. So if the patient is uncomfortable, they're more likely to move, they're more likely to give you more setup errors. So you definitely want to make sure your patient is as comfortable as possible. I always joke and tell them it's not a Tempur-Pedic, but I will try, as much as possible to get you as comfortable as much as I can. When using respiratory gating, choose the best option. The CTV would be drawn where the location of the tumor is during a specific part of the respiratory cycle. The PTV should include the full range of motion of the tumor. The isocenter will move along with the movement of the tumor, and the beam is sustained while patient is not breathing. I'll give you a second there. Okay, and we can show them the answer. The CTV would be drawn where the location of the tumor is during the specific part of the respiratory cycle. Again, the respiratory cycle 4D would be acquired during simulation as we're doing that CT scan. And so from there, that plan will be using the respiratory gating system to actually contour out the CTV. If respiratory gating is to be used during treatment administration, I guess choose the best option. A 3D CT scan can be used for treatment planning. There must be a complete respiratory cycle in each bed position of the CT simulation. Patient evaluation education is not necessary due to the precise nature of IMRT treatments. It is more appropriate for tumors with minimal respiratory movement. Again, I'll give you a second there. Okay, so the answer. And correct. So there must be a complete respiratory cycle in each bed position for the CT simulation. Again, this is the most important part. During this CT simulation, you'll be gathering the 4D respiratory gating information. And so there has to be a complete respiratory cycle during that simulation process. And again, that's what they'll be using to create the treatment plan for the patient. Okay, for each day of the patient's IMRT treatment, the RT should do which of the following prior to beaming on? And select all that apply. I'll give you a couple of seconds to look at those choices. Okay, and we can show them the answer. Okay, and so you've got the 4, which you visually check the patient has not moved from the setup position, check that the treatment plan corresponds with the patient that is on the table, check the machine parameters correspond with the plan, and check the prescription has not changed. All of these are very, very vital before you beam on. In fact, if you have a partner, just make sure that as one partner is probably setting up, make sure that nothing has changed. But again, you want to always double check, triple check everything right before you beam on. Before treatment, comparing the treatment machine parameters with the treatment plan PDF can ensure that, and again, choose the best option. The correct treatment will be delivered, the right patient is being treated, the correct place is in the ISO center, and the patient is aligned correctly. Okay, a couple of seconds there, and we can go to the answer. Okay, and the correct answer is the correct treatment will be delivered. That would be your best option from the choices that you've been given. If the emergency button fails while a patient is on the treatment table, what is the next course of action? Okay, and we can go ahead to the next. Okay, so you want to turn off your circuit breakers. So again, your circuit breakers all control the power going to your LINAC and also your table, all the mechanical controls. So that would shut the power off. So that would be your next course of action. And again, even as you run off to turn off the circuit breakers, again, you also want to make sure that your first priority is the patient as well. Make sure that patient safety also is your first concern. Okay, next.
That seems to be the last slide. Is there anything else that you want to go over? If there are any questions from the participants? So someone asked for question 19. In case using Cobalt 60 machine, is option C not the best answer? Sorry.
Was that the last question? So if you're using a Cobalt machine, which of course is a bit different. So with that one, you would have to actually turn the source. There's a casing where you'd be able to turn off the casing, sorry, the source power. So that would be the first course of action.
Yeah, and there's another question about the same question. So I think people are wondering why you wouldn't take the patient off the table.
And I can definitely see that, because I remember even thinking, well, my first thing would be to definitely take the patient off the table. But you'd also want to make sure that whatever is causing the emergency, so first of all, you want to make sure that you stop the beam, so to speak. And so by turning the source off and then getting your patient, that would be your best course of action, because not only are you, of course, have the patient safety and concern, but also yours as well as the therapist.
So no more questions right now. Maybe we'll just give people another minute.
Okay.
Okay, there's another question. At times during using Cobalt 60 source, sticking the circuit breaker may not be a primary importance because the collimators may not close.
I have to look more into that one.
All right, so it looks like there are no more questions right now. Just as a reminder, there's posted the 3 links in the chat for everyone to use for the Zoom link for the next session next week. Just make sure that you use that link. It'll be different from the one you're using now. Yeah, thank you so much again, and we'll see you next week.
Oh, wait, Andrew.
Oh, yeah.
I think there's
I think Mustefa had some comments, and then Njery has another little mini presentation.
Right.
Oh, right. Okay.
Yeah, just touching up on patient care.
Right.
But I think Mustefa, I believe, was going to address a previous question.
Yeah, if Mustefa, if you want to do that now, that would be great.
All right, this is going to be a very, very short presentation. Njery, I'm sorry taking time from you.
No, you're good.
I'm going to talk about it shortly about IMRT QA, but first I want to talk about, one thing that's needed in radiation oncology or any healthcare actually, or in any business, but more importantly in healthcare. And then more importantly in radiation oncology, because like I said before, once you give it, you can never take it back. It's like once you give the radiation dose, you can't take it back. So we need to have this in a department that was integrity. I'm going to get to it later. So if you ask me one word to describe the radiation therapy, if you want me to describe radiation therapy in one word, safety for the patient, safety for patient, friends, and family, and safety for personnel. So every clinic, we gotta have a culture of safety in place. There's no another way. So every time you think about, you bring a patient to the room, every time you come in the morning or in the afternoon, you come to the consult area, think about safety. Safety for yourself. Make sure there's no any kind of leakage coming out of the room to your consult. Make sure that everything is checked from A to Z before you bring the patient in. Make sure that the patient family who accompany the patient into the room is left the room. That's what we have to always look out for, the safety. The last time when I was at a presentation, I talked about this story from New York Times about a patient, head and neck patient, and he was treated with open MLC. With open MLC, with that open MLC, he was only treated 3 fractions, but he died because of that. But on the second day when he was inpatient, the family member came to see him. His neck and his ear were swollen. You see, you could see that, the breakdown of care. He was in the room, nurses, they noticed that, nobody even reported that one. A second fraction gave him that what you call side effect. Second day, the therapist saw that patient. Think about it. I mean, it's not like therapists have been doing for a long time. They saw that the neck and the head is swollen. Nobody even put the alarm on that one. So that's what I'm talking about, integrity, you know your patient. But today, I'm not going to talk about that because the last time I was talking about it, I talked about the MLCs being open. But the question is, why was the MLC open? That's what I'm going to talk about today. Because they failed to do, when we do IMRT QA, we check everything. Everything is checked, So they failed to do that. Now I'm going to the field. Last time I was talking about the therapists, the radiation therapy side, because they didn't notice the MLC was open. Because at that time the patient was like, he got nauseous, and the therapist was worried that they were looking at it the whole time. They're using the camera looking at him, but they failed to look at those MLCs. But today, what caused these MLCs to be open? They found out the patient got 7 times the prescribed in 3 days, 7 times the dose in 3 days, because the physicist finally did the IMRT QA after the 3rd fraction. Think about it. Even after the next one, the head swollen, they gave him the 3rd fraction. The entire, from the neck, all the way from base of skull and to larynx, everything is swollen. Like I said, they failed to do IMRT QA. That's why I want to talk about today, integrity again. Integrity goes like, from all the way from radiation oncologist, from the doctor, all the way down to it. So last time, Ben, raised the question, we don't know, what inspired that, what happened in the clinic, but I'm just going to talk general right now, we don't point a finger on nobody, but what I'm trying to do is right now, since we are starting this IMRT QA, we transition from 3D to IMRT, this is very, very important to have that integrity. Make sure that a patient, and if you have the knowledge, and if you have the device to do the QA, we have to do it 100% right. If you have the know-how, and if you need to be trained to do it, then we need to be trained to do it. Because so you see, when you go back here, you say radiation offers new cures and ways to do harm. Our goal is to cure or heal. Because the first principle that we aspire to is first, do no harm. This is one of the main medical principles we should follow every day. Every time we come in, first, do no harm. The patient wants to be the first priority. The course of action has to be helpful and avoid exposing the patient to unneeded harm. So please, let's put this, first time I started the radiation, I have this card, I had a card and I printed that and I put in my badge just to make sure that, I looked at it every day. If it helps you, just put it on the wall. First, do no harm. This is very, very, very important for us to follow because, we know radiation cure and kill, but our goal is first not to do no harm. Why do we do IMRT QA? To prevent errors, treatment planning, and treatment delivery and machine performance. We know that once we do the QA, we know that every angle we need, every angle, gantry angle we need is perfect. MLCs are moving the way we want them. That's why we do it. if the IMRT QA was done for that patient that I was talking to, they would have been the patient would have been alive. But what I'm trying to say is at least, we could have avoided that disaster. All right, so now I'm going to go back to my integrity why. What is integrity? Being honest and trustworthy. Think about it. When a pelvis patient, somebody like they have like a tumor, or could be a rectal tumor, any kind of cancer in the pelvic area, they trust you and they come there and they expose their private parts. They lose their privacy because they trust us. They trust me. So I have to have that integrity to make sure that they lose their freedom. A breast cancer patient comes up and take off her clothes, exposing her breast. There's a big responsibility on us. We have to be honest and trustworthy. We have to hold ourselves accountable. This is, like I said, this is like once you give it, you can never take it back. And like I said last time, we are the last line of defense. But you know what? It doesn't excuse the doctors and the physicists not to do their jobs. They have to do their job. The physicists need to empower the therapists. They need to be empowered. They need to know what's going on. We have to have discussion in this one because we all it together. Always stay focused on a task because, like I said, somebody is coming. When I go today, when I finish this, I'm gonna have a good breakfast. I'm probably gonna have some food and I'm gonna have some, I'm telling you, some egg or something like that. But you head and neck patients, they can't even drink water. They come there every day, they're burning inside. But they still come there because why? They believe and trust in you. They trust you because you're gonna cure them. So always stay focused on the task. And uphold ethical principles and policies, any kind of policies you have, uphold it. First, do no harm. Like I said, have a culture of safety in the department and always be being dependable to your patient, to your coworker, and to the patient family. Sorry for interrupting this, but I just want to talk about that. I want to address what happened. At the end of the day, we're here to give the best care to our.
No, thank you. Thank you for reiterating that. So again, just to piggyback on what you're saying, I'm glad you brought it back up again based off of a question that came up from the previous presentations. So thank you for taking the time to address this, because again, as radiation therapists, or just like you said, anyone in radiation oncology, we have a very unique responsibility. And it boils down to really just thinking about any person coming in. And for us, I know at some point it becomes almost like routine. Okay, get your next patient, get your next patient, get your next patient. But really, you just have to stop and think, what if that is your mother? What if that is your loved one? How would you want them to be treated? And so again, like you're saying, they are trusting us. They come to you trusting that you're here to cure them, to help them. So thank you again, my friend.
Thank you.
Okay.
All right, perfect.
All right.
Okay, thank you. Again, this is just going to be a short one. So thank you everyone for being patient. Okay, so we're just going to touch up on patient care. Again, you've gone through all the technical stuff, from, your previous presentations, but then now we're going to end everything with patient care, which is really the most vital, because this is where now we're interacting from one human being to another. So it's not just technical stuff. Okay, so here we go. Okay, so sorry, next. Okay, so the patient, we all know this. They come to you just like this little owl here. I have lots of questions, big-eyed and everything. So it is our job to assess a patient, address any concerns that they have. So they will, of course, come to you with very, very many questions. Again, you have to, the key thing to always remember is, for us, we know what's happening. We know why we're doing what we're doing. But for a patient, it's a very new experience. Again, like I touched earlier on, radiation oncology is such a unique field. A lot of people don't even know radiation therapy exists, or if they do, they have no idea what it really means. So when they come to you, they are going to come with a lot of questions. Radiation therapy is somewhat unique in the healthcare in that we see our patients daily over the course of their treatment. And I will touch on that a little bit later on as we finish up that presentation, but that is, just keep that in mind. Okay, so of course our primary purpose is tumor eradication, but the patient's experience with us also has an important role in their healing journey. Again, these are textbook stuff, but again, now you're dealing with a patient, now you're dealing with physiological, psychological, and even social needs that the patient is going to come with. Okay. Okay, so whether you are in simulation or doing treatments or even both, so this is a really great picture. I love it because we want to go from this, because once you go to the waiting area and you call your patient, that is pretty much the look they have. And it is your job. It's your job. But when you come in and you introduce yourself to a patient, from the minute you meet them, you're assessing them, or at least you should be, because that's part of your role, not just because you have to do it, but because we must do it, because we're here for our patients. So again, they'll come to you very nervous. They'll give you that look of, what are you about to do to me? So every day, like I mentioned earlier, I'm in simulation. So again, this is where everything begins. So they do come to me a lot with that look. Okay, next slide. Okay, so again, they come to you very nervous. So what you want is to transition from that to this. These pictures again are very, they are really sharing the exact emotion that I would want my patients to have. So when you meet your patient, you assess them, and they look nervous. Address any concerns that they have. It can just start off with, how are you doing today? Do you have any questions, as you explain the procedures to them? Again, with everything that you're about to do, you have to explain every single step. One, it alleviates anxiety, and two, it makes them feel more comfortable. They feel that now they have an idea with what's going on, and it makes them feel that they made the right choice to actually come here and do this. So as you can see here, they're smiling, they look like, okay, I can do this, I'm not that nervous. So this is perfect. Okay, a patient who is informed is comfortable and compliant. As radiation therapists, we know this is super, super important, because this, first of all, makes our job so much easier, right? When the patient is compliant, that's really 90% of the time, that's what you want first. You're like, please be compliant. That way your treatment can go by not only much faster, but more accurately and everything. And that's one of the first things, the selling points that I even tell my patients. If you're comfortable and if you're compliant, if you're able to do this, your treatments will go by much faster. And so you won't have to be on the table longer. So you definitely want to keep your patient informed. Again, this is where it's so important to just take the time, not just look at your schedule, not look at, see where, we're 15 minutes, we're running behind. Yes, the schedule is important, because of course, without a schedule, everything would be chaotic, but you want to make sure you take a step back, make sure that you're addressing whatever questions, verbal or nonverbal. There's some cues, nonverbal cues, that you need to be able to pick up from your patient and address that, because you want to make sure that they are still comfortable and that they are, again, that they're going to be compliant. Okay, again, a patient who is involved participates in the success of their own care. Again, I'm sure as you've seen this throughout your career as a radiation therapist, that when they're involved, when they feel that they have some kind of control because they have the necessary information that they need, they also want to contribute to the success of their own care. This could be anything from addressing any concerns about, like, let's say, how to keep their marks, who's going to, how do I look at my appointments? When do I get to see the doctor next? Can I always go and see a nurse anytime? So these are questions that we as therapists should be able to answer, because again, back to that very point that I said, just keep in mind, patients see us on a daily basis. They get to see us more than they see their doctors or any other person in their care team. So we are very vital in their journey. So again, you're constantly assessing your patient every day, every moment. If they have any concerns, it's also your job to go ahead and communicate that with the rest of their care team, be it the doctor, the nurse, everyone else involved in their care. So, and again, just again to tie on with what with Mustefa's presentation, they're here for us. They have put their trust in us. So these are the things that we want to make sure that we're addressing. Patient care is so important, because not only do you want them to leave there with the tumor eradicated, but it's the experience. You want the patient to leave you when they're done with the treatment saying, they cared for me every day. They were compassionate. They showed empathy. They showed love. This is what they will remember. Patient communication, super vital, very, very important. Again, I know the drill. Sometimes we just want to get on with it. You're looking at the schedule, you get your patient and you're explaining things. And again, always remember, the key thing is you'll stop and remember the patient. For them, this is a totally new experience. They have no idea how the motions go, what the flow is. So again, always communicate with your patient. So like I said, the first things first, always introduce yourself. When you introduce yourself, that makes that patient feel that you are communicating with them, that you want to get to know them. Introduce yourself. They need to know who is going to be in charge of their treatment or their simulation. Okay, again, if you're in simulation or treatment, explain everything. Explain why they're doing this. Confirm, first of all, that they are aware, okay, this is the simulation process, correct? Okay, we're simulating for, we'll say for breast or for pelvis or your spine. So make sure that you're always keeping the patient informed and addressing any concerns that they have. Tell them what you're going to do. How is it going to feel? So a lot of times when they come for simulation, I'll touch on simulation, then of course with treatment, but with simulation, once I introduce myself, I'll tell them we're going to be using these devices to immobilize you. We're going to take a series of CT scans. This is going to take about 15, 20 minutes, possibly 30 or 40 minutes, depending, of course, what we're simulating for. Again, let them know what you're doing every step of the way. They have no idea what you're doing. And let them know how long it's going to take. A lot of times they are also concerned maybe about their loved one who's outside in the waiting room. So just let them know this is going to take about 20, 30 minutes. And again, key point that I always do, a little tip is as I'm walking them back, I do tell them this will take about 30 to 40 minutes. Would you like to use the restroom? That way, again, we want to make sure that you're cutting down the amount of time that the patient is on the table too. Will it hurt? This is a very popular question. You're not going to see anything. You're not going to feel anything. Again, touching on what to expect. Let them know if this is for treatment, you'll let them know that the first thing that you're going to do is once you align them, you'll be taking some images and then you'll be delivering the treatment. So again, let them know what you're doing every step of the way. Let them know also when you're doing your imaging, when you're removing your imaging panel, I always like to tell my patients, you might see the imaging panel come up above you. It'll come close, but will not touch you. Let them know, because at least now that they're aware, they won't try to jump off the table thinking, oh my God, that image is about to drop on me. So again, just let them know what you're doing every step of the way. Okay, what you should tell your patients. So again, this also just addresses, this also touches on letting them feel empowered. Let them know what they need to do. So again, if this is simulation, usually we'll have them remove everything, probably from the waist down or waist up off, or possibly everything, just depending on where the area of interest. So you might tell them, go ahead, remove your clothes. We're going to give you a gown instead, or we'll give you a towel to just wrap over the area. Okay. A popular question: what should I do if I sneeze or cough? Just tell them, don't bring your arms down to cover your mouth, just cough straight up. It's not a problem at all. Okay, and again, we can see them and hear them at all times. Keep your marks on. This is now after you're done with maybe your first day of radiation treatment, or even for simulation when we're marking them, putting some tapes on, let them know how important those marks are. Okay, any special instructions? I like to call my patients the day before, especially if it's, as it's saying here, like a bowel or bladder prep. So for some patients, like prostate or prostate fossa, or even the gynecological, we'll probably need some prepping as far as maybe having a full bladder or an empty bladder. So that'll also just depend with what the physician's instructions are. Okay, so it's always good to just let them know ahead of time, because especially for patients who are a little bit older, who might not have access to like their electronic chart. So you want to make sure at least you call them, let them know when you come for your appointment, make sure that you have had a bowel movement or come in with a full bladder. Okay, as far as for breathing instructions and how respiratory gating works, that will be, of course, during simulation. We do give a brief explanation of how it goes. And again, we coach them throughout the simulation process. Okay, so remember, the patient can see what you're doing. Again, tell them what you're doing before you do it. I'm going to move you, lay heavy, don't help me. These are things that they seem very obvious, but for a patient, not so obvious. And we all know that, because anytime you go to move your patient, they want to help you move their hips, move everything. And we work in millimeters. So again, just always tell them what you're about to do. Okay. Again, even something like placing the bolus on their skin. Usually what I usually do is for the first day of treatment, I do show them the bolus, let them feel it. That way, when does come time for me to put the bolus on their skin, it's not something that they feel that is foreign. At least they'll remember, oh yes, I remember she said something about some squishy material that's going to be on my skin. Okay. Again, so we all do this, but we all want to make sure that we don't, or at least consciously don't put objects like scissors or like the chart on top of the patient as if they were a table. For us, it almost feels like it's like second nature, but honestly, that's just one of those things. Just don't do it. Use the foot of the table. There should be some space, or bring a cart next to you if you need to have some items, like whether it's the tapes or the Sharpies, what it is that you're using to put on the patient. Okay, next. Again, this is just touching up on patient education. A patient who is informed is comfortable and compliant. One who's involved participates in the success of their own care. Again, just super vital that they feel empowered. I think that was it. So thank you for your participation in this course. Thank you so much. Again, patient care, super important. Please always remember your patient does not know what you're doing. This is their first experience. And even if it's not, if they're coming back maybe for a second round of therapy for a different site altogether, you still have to show the same level of patient care, if not higher. Again, because they see us on a daily basis, we are very, very important. We are the ones who assess these patients, again, on a daily basis, letting them know what's going on, and keeping also, again, like the care team involved. Okay, so don't take patient care as just a small thing. It's very vital. Your patient comes first. Thank you.